And we are a go. Good afternoon, everyone. And it is my pleasure to welcome you to Dear Peri Sister. My name is Dr. Fiona. I am the founder of Black and Peri. And Black and Peri is a femtech startup I created to help provide service for Black women who are in midlife and beyond. This midlife transition can be quite a challenge. And so that's why I created Black and Perry. I pivoted my health and wellness business. So today I am super excited. We have Dr. Jane Morgan with me. And so, Dr. Jane, how are you?
How are you? Hi, Dr. Fiona. Nice to be here.
Likewise, in terms of having you here. We've been communicating for quite some time, all some half of the summer, I would say, and finally we have the chance to work together. So I'm excited for that. If you would, let's just kick it off. Make sure we use the time wisely. If you would tell us about you, tell us about your work.
Sure. I am a cardiologist and have spent really most of my career in research. I certainly have quite a bit of patient facing experience, but really had a passion for research and have been in the industry at Solvay, AbbVie, and then most recently at Piedmont Healthcare, leading their research program and then transitioning over into education. Currently, I'm the Vice President of Medical Affairs for Hello Heart, which is a digital heart health company. And we're doing a really big focus on women's health, which is also a really huge interest of mine, which is why I'm joining Dr. Fiona today, actually, to talk about women and to talk about midlife and all other aspects of what happens in a woman's life, especially as it relates to the heart, especially as it relates to cardiology, but really everything, the entire body and what that means for women's health. Why aren't we represented in research? Why aren't we represented in clinical trials? Why don't we have therapeutics that are specific to us? Why isn't there funding? So on and on and on. So I spend a lot of time in this space.
So, of all the hats that you wear, tell me which is top two favorite hats that you wear because you wear multiple hats.
Yeah, and I think women's health and health equity are probably the two top hats, both as they connect to heart disease and cardiology and how it impacts both of those communities.
Got it. Okay, so let's good introduction. Now we know a little bit about you and your work, which is fantastic. So let's get into some of the things that we, as Black women, need to be talking about as it relates to menopause transition and heart health. So could
Mhm.
you start by sharing the impact of menopause transition? So people say menopause, but it's actually the transition and the different stages of it. So, thinking about the different stages of menopause transition or the cycle, what is the relationship between those phases and heart health?
So, really we look at perimenopause and menopause, and often I hear people speak about postmenopause, which is actually a term. But the fact of the matter is, once menopause starts, then that's really it. That is postmenopause. And menopause is once your menstrual cycle stops for a full 12 months, you are officially, formally in menopause. Some people call that postmenopause, but that's actually menopause. Prior to that, still having regular monthly cycles, or they've started to become irregular, then that's the perimenopause phase, which really can start as early as your mid to late 30s. And most people don't realize that. So, the interesting thing about perimenopause is that you can already be experiencing some of the symptoms of your estrogen levels dropping and starting to move towards menopause, but also still have regular menstrual cycles, still be ovulating, and still be at risk of getting pregnant. So both things can be happening at the same time, just to add a little fun to it, which is why many women in perimenopause, especially in 30s and 40s, aren't aware of it because they're still having monthly cycles, but they're also having all of these types of symptoms that they can't really pinpoint. It can't really attribute to anything. It's not all about hot flashes and night sweats. There are a myriad of other symptoms, vague, seemingly unrelated things for which you may not even seek medical help, or you may go to a doctor and they can't really put it together. They don't know why those things are happening. You may be sent off to different specialists. And really, it's all a function of the estrogen levels dropping and multiple symptoms starting to occur.
Right. So in terms of perimenopause, so that's the before the
Mhm.
cycle stop. So what kind of concerns do we have there, or should we be thinking about when it relates to the heart health piece?
Yeah, we should be really concerned because that sort of marks the time when our estrogen levels are decreasing. And I specifically focus on estrogen because estrogen has a couple of functions other than fertility. It is an anti inflammatory agent. And we know that chronic inflammation is one of the risk factors for developing heart disease, developing atherosclerosis, that hardening of your arteries. It also has a protective effect on the heart itself, the estrogen and estrogen receptors. And so, as we begin to lose more and more of that estrogen, that means that our risk of heart disease increases. And so, we think about estrogen, you think about, oh, just the ovaries, but it's not in the ovaries, in the heart, it's also in the arteries. And so, what happens? Our arteries can start to become less pliable, meaning they are not as elastic and become stiffer, more like tubes, say, than rubber bands. And because of that stiffening, you can have an increase in blood pressure. And oftentimes people who've never had high blood pressure can start to note when they're going to their physician's offices that their blood pressure is rising. You're not attributing that to perimenopause. Like, oh, I've put on a few pounds, or oh, I may be eating indiscriminately. And the fact of the matter is, it's because of the stiffening of your arteries. And so that as well is a risk factor for heart disease. Hypertension, high blood pressure becomes a risk factor for heart disease. You might notice your cholesterol levels, if you're getting them checked, start to go up. That's because estrogen and cholesterol share a common pathway, a metabolic pathway in the liver. So those estrogen levels are dropping. You may find that your cholesterol levels are increasing, and you may refuse medication for it because, oh, I just need to exercise more. I just need to change my eating habits. And both of those things may be true, but it's also signs of perimenopause. And we just aren't aware of it. And that impacts our heart disease. And then things that we may know about, but may not attribute them to perimenopause because we may think we're too young. And that's just disturbed sleep. You have sleeplessness,
Yes.
you have insomnia,
Yes.
and that doesn't mean that you don't sleep at all. It generally means that you actually can fall asleep, but you have frequent awakenings, or you
Right.
awaken 2 or 3 times, so you can never get a full night of restful sleep. So it's not just the
Right.
inability to fall asleep, it's also the ability to fall asleep, but the inability to stay asleep. That's also
Right.
insomnia. And we know that the duration and quality of sleep is also directly related to heart disease, at least 5 hours. If you get less than 5 hours or not, you have an increased risk of heart disease. All three of these things are happening during menopause, in addition to estrogen levels dropping, in addition to, increased risk. And so I try to talk with women about that to make certain that we understand that prior to menopause, a woman's risk of heart disease is only half that of a man. But then once you transition through menopause, your risk equals that of a man's. That's how protective estrogen is to our bodies. And that's one of the areas where we really don't want to be equal to a man. We don't. We want to enjoy our
Right.
advantage,
Right.
and not have equality there. But
Right.
that's what happens. And because heart disease is considered a man's disease, there really isn't a lot of focus on women. And even if women seek medical care with their physician or in the emergency room if they're having symptoms, oftentimes you can be dismissed as being depressed or anxious, and be sent out when in fact you might be having a serious cardiac event.
Right. Right. I love, we need to unpack what you said, right? Because
Mhm.
you said a lot. And so some of the things I heard, which I think is very important, because I also work with women, and I just wrapped up Peri Everywhere
Mhm.
virtual menopause summit.
Mhm. I
We
know. Great
we missed
summit.
you, but here we are. Here
Here
we
we are.
are. So you talked about the fact that this period is more than just hot flashes, right? It's more than hot flashes and night sweats, because we hear so much about it. We hear so many jokes about it that we oftentimes neglect the fact that it's the effect of estrogen being more than just a sex hormone, right? It's a lot more. So I love that you talked about the heart health risk. This is very
Mhm.
important in relationship to our transition. I love that you talked about the relationship to sleep. I love that you talked about all the other things. In fact, we know that there are like almost 34 different symptoms that
Mhm.
we can experience. I'm really glad that you talked about everything, because just focusing on hot flashes and night sweats is really going to do us a disservice if that's all we talk about and
Mhm.
that's all we focus about.
Mhm.
So talk to us about black women. So we heard, like, in a general sense, what this heart health about is in this
Mhm.
period of our life, but
Mhm.
specifically to black women, what would you say to us?
So I would say hot flashes are not innocuous, meaning they are not nothing. There's not a ha ha. Just as you said, Dr. Fiona, we laugh about it. Look at what's happening to her. But we actually now know, and this is from the American College of Cardiology, and they presented this data in April in Atlanta. And I was at that lecture, that the more hot flashes you have in a week, the higher your risk of stroke. So hot flashes have a correlation to stroke and probably heart disease. So it's not really a laughing matter. And why is this specific? Why is this important to Black women? Because Black women tend to have more hot flashes than white
Yes.
women, and they tend to be of greater intensity. And now we're learning from the American College of Cardiology that there's an association with an increased risk of stroke the more of these hot flashes that you have. So that is a risk that is specific as well to the Black population and to Black women. The other thing to think about is that in general, Black women will enter menopause a year and a half earlier. And while many of us celebrate the end of having to deal with the menstrual cycle, the fact of the matter is, from a cardiac perspective, we've lost that protection of our heart that much earlier. And therefore, when we look at mortality data, that means death data, and morbidity data, meaning illness, there's no surprise when we see higher incidence of heart attacks in Black women, higher incidence of stroke. And it's also obviously related to socio-demographics, social determinants of health, socioeconomic types of foods that we're eating, weight, and all of those kinds of things. But it's also related to the fact that many of us lose that protection of estrogen earlier as well. It's very specific to Black women and specific to Black women living in the United States, not specific to Black women outside of this country.
Great. So a follow-up question. Talk to us about when we are entering this phase of our life and we have a pre-existing medical condition, such
Mm.
as you mentioned, high blood pressure and high cholesterol. So talk to us about what we should be thinking about if we enter into our midlife transition that way.
Right. And many people will already have high blood pressure and have high
Mhm.
cholesterol. And hopefully you're being treated for it and you are taking your medications
Mhm.
appropriately, right? Because I hear patients say all the time, well, I just don't want to be on medications because they like to say, I don't take any medications. Well, the fact of the matter is that's nonsense. I would rather say that I take two medications for high blood pressure and cholesterol and I have them controlled so that I
Right.
now have lowered my risk for heart disease than to be able
Right.
to say, I don't take any medications, but my blood
Right.
pressure's up, my cholesterol's up, so therefore my risk of heart disease and stroke.
Right.
So that just makes no sense to me, but I know
Right.
psychologically, people
Right.
feel that they're getting older if they have to take medicine, so they resist it. But the opposite is true. You are artificially advancing the age of your body and the disease processes in your body by psychologically telling yourself you're young by not taking your medication. So I just want to say that it's a psychological trick that you're
Mhm.
playing with yourself. And the fact of the matter is to stay young, keep all of these indicators that are risk factors for your heart disease under control, including taking your medication. So I say that to say many of us can go into menopause already have high blood pressure. So what happens when those estrogen levels drop and our arteries begin to stiffen a bit and our blood pressure rises? If you already have high blood pressure, you can expect your blood pressure is going to go up even further. If you already have high cholesterol, it will go up even further. Now, this is not for everyone, but unfortunately, it is a fact for most people. And then on top of that, what do we usually say when, we're dealing with blood pressure and cholesterol? We need to exercise more, we need to lose weight. But because of the metabolic changes in our body with the loss of estrogen, you also begin to put on weight. And you begin to put on visceral fat, meaning weight around your midsection, which is the most unhealthy and the most inflammatory. So we're back to that word again. Inflammation increases your risk of heart disease and increase your risk of cancer and increase your risk of arthritis. I'm just going to stick to heart disease today because we don't have a lot of time. But there are a lot of ands to that as
Yes.
well. And so
Yes.
visceral fat, that fat that starts to sit around your stomach and your midsection is very hard to get rid of. And you may begin to realize I'm exercising the same, I'm eating the same,
Yes.
but I'm gaining weight. And you go and see your doctor who says, oh, you're not exercising enough, or you've got to exercise even more. And then you start to exercise even more and you never lose weight. That is inherently the issue now with perimenopause and menopause. And that visceral fat in particular, is a risk factor for heart disease more than any other types of fats. The one of the better ways to combat that is to adjust your eating to
Mhm.
eat foods that are anti-inflammatory. And I know we don't have a lot of time left on this podcast.
Right.
I will just say at a high level, foods that are anti-inflammatory are more plant-based foods.
Right.
And that
Right.
helps you reduce the buildup of that visceral fat around your midsection. And then when you are exercising, think about either adding resistance, meaning a little weight, or switching to the types of exercises that create resistance.
Right.
So you can actually create and increase muscle mass. Muscle burns more calories than fat. So things like Pilates gives you that resistance, that muscle resistance by using your body, but also, just lifting weights. I'm not a
Right.
proponent of lifting weights, but a lot of people do. A lot of people wear weight vests. A lot of people do these. So find
Right.
something that you can do and do that because obesity and central fat around the middle, another risk factor for heart disease that occurs
Right.
during menopause. So all these menopausal symptoms are not ha ha ha. They actually
Right.
are increasing our risk of heart disease.
Right.
And even doctors still are not aware of it. I've been beating this drum now for 3 years. We're just starting to kind of come to the forefront of it. So if you listen to this podcast, may go and see your doctor and have more information than he or she does about
Yes.
so.
Yes, yes. So this is fantastic, Dr. Morgan. So we talked about risk factors. We talked about the fact that estrogen is not just about related to us being a sex hormone, the impact of estrogen on our entire body
Right,
system,
right,
especially the heart.
right.
We talked about some of the things that we can do, like if we're on meds, we need to be
Mhm,
taking our meds.
mhm.
You just mentioned lifestyle and leveraging our lifestyle.
Right.
Anything else in terms of actionable steps, in terms of lifestyle or
Mhm,
preventive screenings?
mhm. You definitely want to think about preventive screening. It's not a bad idea to do two things. Get a calcium score, which is actually a type of X-ray. I want to be clear about that. Sometimes I talk about calcium scores and people think it's a finger prick or some type of blood draw. It's actually a type of X-ray, like more like an MRI or CAT scan, and it looks at whether or not you have calcium built up in your arteries. Calcium in your arteries is an indicator of more advanced atherosclerosis, so hardening of the plaques of your arteries. A normal score is actually 0. There is no, 1 to 5 is low, 5 to 10 is there. The normal score is 0, and hopefully you'll have a 0. But if you don't have a 0, it doesn't mean it's not a death sentence. It just gives your doctor information as to how you need to be managed and what type of lifestyle changes that you need to make. It is not an indicator of you taking other exams. People always think, I'm getting the calcium score, so I know what test I need to have. No, it is a risk assessment tool, and it gives your physician an idea of what your risk is in the next 10 years of having a heart attack. So that's one thing. The other thing that people don't talk about is a type of cholesterol called LP little a, LP parenthesis, lowercase a parenthesis, which is more specific to the Black population. So now we're talking about menopause, to be Black females, but also to South Asians. And this type of cholesterol also confers a much higher risk of heart disease. Doctors don't often test for it because we don't have a treatment for it. And here's a secret: we don't really like to test for stuff that we can't do anything about.
Right.
Fact of the matter is, if you have an elevated LP little a, and generally that's higher than 30, your doctor really knows now to talk with you about more intensive lifestyle changes. Like your blood pressure, if it's hanging out at borderline, we can't tolerate borderline any longer. Got to get you on medications, get it down to 120 over 80. Your cholesterol borderline, got to get it down to much lower levels. So we begin more aggressive intervention if your LP little a is high. And the good news is that there is some therapy coming, maybe in 2025 or 2026. I sit on one of the steering committees of these drug companies. We've been working on these trials for a number of years, and we are nearing the end of our phase 3 trial. So there may be therapy coming, but in the meantime, there is something you can do, and knowledge is power. And sometimes knowing that you have elevated scores might be motivation enough for you to make lifestyle changes.
Right.
Maybe you've been a little bit too lazy to make lifestyle changes, but now if you get these tests done and you find out your risk is higher than you thought, and we don't actually have a cure for it, you got to
Right.
actually cure yourself.
Put some work into it.
That might be the motivator, that you need,
Right.
what, how you're made up psychologically and what's going to motivate and drive you.
Right, right. So I have just a few more questions and we'll wrap it up. As you were talking about the testing, and we mentioned a little bit about the meds, and talk to us in terms of being Black women. We know that overall, not just Black women, but communities of color, we have some concerns around equity and access to care, right?
Mm-hmm.
Appropriate care, but especially for Black women, thinking about studies like the SWAN study, where we're less likely to be offered appropriate care
Mm-hmm.
for this season of life. How should we go about navigating that, advocating for ourselves? Because I don't remember being offered an LPA,
Mm-hmm.
the option to do the LPA or the calcium testing.
Right, right. Um, you know, that's one of the reasons we do these podcasts. And that's one of the reasons that I get up every day and try to give information to the public. It's such that you can be armed with information so you can advocate for yourself. So you know what questions to ask, what it is that you'd like to do, what you'd like to have and why. And I get up every day and do that. And so if anybody's interested in following me, I'm at Dr. Jane Morgan, DR, it's just DR, JAYNE, MORGAN. And I'm here on LinkedIn, on Instagram, on X. And I really give some medical advice every single day. I talk something about medicine. I do multiple media interviews. I'll post the media interviews. But really, if you're on my page, you're hearing little tidbits about science and medicine all the time, because really science is for everyone. And I really demystify it. I try to make it relatable, make sure you can understand it, and not only understand it, that you can then repeat it to someone, and
Right,
you can voice what it is
right,
that you want and why, because I've
right,
given you the tools and the words and the information to
right,
use.
Right. And I just want to take this time to say thank you. I do follow you. So again, let's follow Dr. Jane,
Mhm,
Dr. Drjayne
mhm.
Morgan. So her name is spelled there is Dr.
Thank you.
Jane Morgan. So let's follow her. So I've seen
Thank
the Wednesday Staircase
Yeah.
Chronicles. I love those. Those are great. And I've seen you in, doing your PR, and I love it. So I want to acknowledge and thank you so much on the
Thank
behalf
you.
of all of us, for getting up every day and passionately doing what you do. It's
Thank you.
amazing. You look amazing doing it, and the world is so much better for you
Thank you.
doing it.
And
Yes,
Mr.
let's.
Sharon, I would say one other thing, I have a talk show that is starting on Friday, November 1st. This is 2024. And you can view it on YouTube, or you can come to my page. And I can just, direct you where to view it. If you come to my page, I can send you to where to view it. But the talk show is called Healthy Her. And all I do is focus on the health of women. It's all about women's health. So I've filmed 6 shows already. They're all geared towards women's health. Will probably be picked up for more. So make sure you watch it. Submit some topics that you want to hear about, and maybe we'll talk about them. I have guests on who are experts, and I just lead the discussions. So this really is my passion.
Congratulations.
I want to focus on women's health. And so we're trying to continue to go down that road.
Right. Congratulations. I'm going to
Good.
follow and do all the things.
Okay.
So we talked about navigating the healthcare system. You did mention a little bit about being involved in the clinical trials in terms of representation in research and clinical trials. So we're wanting solutions as Black women that are tailored for us, right?
Mhm,
Um,
mhm.
how do we make that happen?
Yeah. And so, we want to make certain that we've got representation in clinical trials, um, because it's important that drugs and devices that go before the FDA for approval are relevant to us and relevant to all populations. And that generally has not been the case. Part of that is because there's not leadership in research that looks like me and that looks like you. And when there are opportunities for leadership, that leadership is not promoted into any position where decisions can be made that really impact patients downstream that look like you and I. And that's not by happenstance, that's by design. And that's part of the patriarchy, and the white male patriarchy of they are the owners of intelligentsia. And therefore, they lead all of the research programs and they lead science. But the fact of the matter is, it's such a myopic view. And if you don't have other people at the table who have broader perspectives, experience, and knowledge than you do, even though we're not white males, are actually better prepared to manage the population, this is what you have. So part of that is because leadership doesn't acknowledge it. And I'm not even saying leadership is racist. I'm saying they don't get another perspective, right?
Right.
So all
Right.
the people at the table reinforce the thoughts of everybody else at the table. They all agree,
Yes.
or the thoughts were introduced. We're doing a great job, right?
Right, exactly. Absolutely.
Right,
Yeah, it's not
right,
racist, it's just a lack of diverse thought,
right.
right?
There are no other
That's
no
it.
other perspectives are introduced, and they don't
Right.
have the lived experience to bring that in, as opposed to minority communities always have that lived experience because we live in two worlds all the time. So we have
Exactly.
more of a 360-degree view of the world and the population, than the majority population most of the time. There are some exceptions, but generally I found those exceptions, they have been intentional in trying to
Mhm.
find out and trying
Yes.
to immerse and trying to have relationships and friendships.
Yes.
But for the most part, without that intentionality, there's always a blind spot.
Right, right. You said it. I won't say anything about it. You hit
Yeah.
it on the head. Part of my role is in an academic setting, so I totally get it.
Well,
As
thank
we
you
are,
so much.
what
Yeah,
was
and I
that?
really appreciate it. I said, thank you so much for having me on today. I really appreciate it.
Yeah, yeah. As
Thank
we
you
are
very much.
wrapping up, um, can you two things? Number one, talk about the cultural things that we have unique to us as Black women that we should celebrate, that we bring that is positive. So we talked about some of the things that we need to work on depending on where we are in our transition. But what about, we come, beautiful Black sisters come together. We have so much that we bring to this part of life. What can we leverage as Black women in our culture and just as women?
Right. I mean, our brain power. Black women are the most educated demographic in the United States. Not only are we the most educated demographic, surveys show that we're the most educated. We're also the most ambitious demographic, more so than white men, but the least supported and the least likely to move ahead. And so if you can't get ahead by following the rules in the United States, education is supposed to be the key to moving ahead, but it doesn't apply to Black women for the most part. And part of that is because we are a readily identifiable minority. And minority groups that are readily identifiable have had the most difficulty in moving ahead. And so here we are as Black women. We have two things that are readily identifiable. We are women, readily identifiable, and Black. Generally, both of those things make it difficult to move forward because of the social construct of the United States of America. Those who can be less identifiable immediately have more opportunity, and those groups have more opportunity. And we see that as well in voting patterns and how people try to align themselves. But the fact of the matter is, othering eventually applies to everyone. And
Right.
if you think you can escape othering by your appearance, at some point it does come back to you. It may not come first, but eventually it will come to you. So you need to think about, where you want to make certain that things go in the right direction for everyone, because it's an interdependent society.
Yes.
And othering eventually is going to impact everyone. But
Mm,
thank
thank
you so
you.
much, Dr. Fiona. I have to
Yes.
go, and I appreciate everything.
All right. Take
All right.
good care. Thank you so
Bye.
much. Bye bye.